في المكان، وأحب أقدم صديقة العمر وأختي الأستاذة الدكتورة إيمان منصور. She's a very eminent hematology in قصر العيني University. هي head of the hematopathology unit in our department. وهتقدم لنا talk على bone marrow failure disorders, challenges in diagnosis.
بسم الله الرحمن الرحيم. أنا بيشرفني المشاركة للسنة الثانية في المؤتمر بتاع اسكندرية. بشكر الدكتورة عبلة لدعوتي، وبشكر الأورجنايزنج والساينتفك كوميتي، ودعوة مشرفاني الحقيقة. وابتدي بقى التوك عشان الوقت ما يخلصش. Bone marrow failure is a potpourri of diagnostic challenges. It's a life-threatening disorder characterized by peripheral cytopenias due to decreased or ineffective hematopoiesis in the bone marrow, affecting a single lineage or all three lineages, and consequently the myelodysplastic syndromes are now considered a bone marrow failure disorder with associated cellular dysplasia. Both of them are caused by decreased fitness of hematopoietic cells and poor hematopoiesis. The marrow-cellularity in cases of bone marrow failure may be hypocellular, normocellular, or even hypercellular. The hypocellularity of the bone marrow is defined as a reduced age-adjusted bone marrow cellularity and or bone marrow cellularity less or equal to 25%. Bone marrow failure with hypocellular bone marrow is the topic that we're concerned with in this talk. It may be caused by inherited or acquired causes. The inherited causes include Fanconi's anemia, dyskeratosis congenita, Schwartzman-Diamond syndrome, inborn errors of immunity such as the X-linked lymphoproliferative disorder, congenital amegakaryocytic thrombocytopenia, which very early in life proceeds to a complete aplastic anemia, and the myeloid malignancy predisposition syndromes, namely the GATA2 deficiency, the SMAD9 and SMAD9 ligand disorders. Among the acquired causes, the idiopathic aplastic anemia, hypoplastic MDS, anorexia nervosa, and aplastic anemia, secondary to medications, toxins, autoimmune disease, or viral infections. The hypocellular bone marrow failure is an overlap syndrome. And why is it an overlap syndrome? As 10% of patients with aplastic anemia will later develop MDS or AML, the late onset inherited bone marrow failure syndromes occurring in adult patients, and the germline GATA2 mutation presenting with a hypocellular bone marrow with features overlapping between aplastic anemia and hypoplastic MDS. PNH clones develop in 25% of aplastic anemia patients, with 2/3 of which occur in patients without clinical hemolysis. Most bone marrow failures, especially the acquired forms, have a mean clone size of approximately 11%. So we have still to differentiate for another disease that does not belong to the bone marrow failure syndromes, and this is the hypocellular AML. As it has been reported by Song et al. In 2021 that a low concordance rate of 57% was found among a group of hematopathologists diagnosing hypoplastic AML, and in 6.7%, as reported by Eric et al., hypocellular AML were misclassified as hypocellular MDS. So what are the difficulties in differentiation? The age incidence. As we can see here, although the inherited bone marrow failure syndromes are predominantly diagnosed in childhood, yet the clinical phenotype and penetrance may be variable, as 10% of the newly diagnosed, 10% in this area, مش عارفة هو البوينتر مش أنهي واحد البوينتر؟ أشاور هنا؟ لا أنا عايز أشاور على اللي فات. مش شغال خلاص؟ مش مشكلة خلاص. ممكن نرجع تاني؟ بس اللي هي the overlapping area where hypocellular MDS is the most common MDS occurring in pediatric patients. Acquired aplastic anemia in 10%. We have a germline lesion, which is an occult inherited bone marrow failure germline lesion. And in addition to that, we have cases of inherited bone marrow presenting in older patients. Number 2 difficulty is the morphology. They all have common empty marrow morphology. It's a hypoplastic morphology. Overlapping features occur between the aplastic anemia and the hypocellular MDS, including macrocytosis, which is common to hypoplastic MDS. However, we can see it in aplastic anemia with paroxysmal nocturnal hemoglobinuria clones. Both a hypoplastic MDS and aplastic anemia may show mild erythroid dysplasia with mild to moderate myeloid dysplasia. The majority of hypoplastic MDS are in the category of refractory anemia, where blast cell count is not elevated. In addition to these overlapping features, sometimes hypoplastic MDS show a mesenchymal reaction which is specific of the aplastic anemia, including increased mast cells, lymphocytes, and reactive lymphoid follicles. In addition, the low cellularity of the aspirates in these patients compromise morphologic evaluation. Other overlapping features between the aplastic anemia and the hypoplastic MDS include that they both respond to immunosuppressive therapy. They show common somatic mutations such as the DMT3A, the ASXL1, and the PIGA. And PNH clones, although more common in aplastic anemia, they still rarely present in hypoplastic MDS. According to US hematologists, karyotype, a presence of a normal karyotype is equivalent to diagnosis of aplastic anemia, while abnormal cytogenetics is more compatible with the diagnosis of an NDS. However, exceptions exist. Benign random aberrations or clonal abnormalities, including loss of the X or the Y chromosome, are present in elderly females or males, respectively. 50% of the MDS patients lack abnormal cytogenetics. Monosomy 7, which is one of the MDS-defining cytogenetic abnormalities, is present in the SMAD9, SMAD9 lichen, or the GATA2 variant, and have been reported in Fanconi anemia, dyskeratosis, and Schwartzman-Diamond syndrome. Still, karyotype analysis is technically impaired in cases of bone marrow hypocellularity. So why do we have to differentiate? We have to differentiate because the common pathology of an empty bone marrow is not treated similarly. If in cases with physical or chemical damage, the main lines of treatment include hemopoietic growth factors, support, and bone marrow transplantation, while in the immune destruction, which is the idiopathic aplastic anemia, immunosuppressive therapy, bone marrow transplantation, and L-thrombopac are the line of treatment. In constitutional genetic defect, the treatment comprises of sex hormones, bone marrow transplantation with specific precautions, as bone marrow transplantation requires special conditionings in these protocols in this constitutional genetic defects. In addition, infection prophylaxis will be required in the GATA2 and the X-linked lymphoproliferative disorder. Presence of a paroxysmal nocturnal clone in cases of bone marrow failure may benefit from the addition of eculizumab to the treatment regimen. So what are the clinical and laboratory differentiating features? Clinical history and physical examination are mandatory to differentiate the acquired from the inherited aplastic anemias with congenital abnormalities, multi-organ involvement, recurrent infections, warts throughout life, long-standing or progressive cytopenia, family history of increased solid or hematological malignancies, cytopenias or congenital abnormalities favor a diagnosis of constitutional in addition to positive consanguinity. On the other hand, the acquired, there's no organ involvement, the onset is acute with previously normal blood counts. Preceding hepatitis or autoimmune diseases may be found, a thrombosis or abdominal pain if a clone of paroxysmal nocturnal hemoglobinuria exists, but family history and history of consanguinity are absent. On physical examination, limb abnormalities, skin changes, pigmentation, cardiac defects, syndromatic facies, poor growth, short stature, early hair graying, all point to constitutional. When the acquired, there's non-specific except for petechial hemorrhages or pallor, or in cases preceded by hepatitis, jaundice. Laboratory investigations will include bone marrow, peripheral blood, first of all peripheral blood for the pancytopenia, monocytopenia and lymphopenia occurring in the GATA2, macrocytosis, blood film for dysplasia, large platelets, polychromasia, reticulocytic count, and platelet function tests as abnormal aggregation is found in the GATA2 and the RUNX. Bone marrow examination, both aspirate and biopsy for morphology. to detect significant dysplasia, which is a characteristic of hypoplastic MDS, but how it's still present in SDS, FA, and RUNX X1, and they do not represent a transformation to MDS. Dysplastic megakaryocytes are characteristic of the RUNX1 and the GATA2, and the Emberger syndrome of the GATA2 pictures showing hypoplastic and monolobated megas. Morphological findings in favor of MDS: dysmegakaryopoiesis and severe dysgranulopoiesis, any elevation of blasts, ringed sideroblasts, bone marrow fibrosis, and clusters of CD34 positive cells. Flow cytometry will be performed on both peripheral blood and bone marrow aspirate to detect the PNH clones, the BT subset lymphocytes, monocytes, and the bone marrow aspirate for CD34% and presence of large granular lymphocytosis. A positive PNH clone is more with a diagnosis of acquired aplastic anemia, as it is negative in the inherited and in the hypoplastic. Lymphopenia and monocytopenia raise a differential diagnosis of the GATA2, where they are normal in acquired aplastic anemia. CD34% increased only in the hypoplastic MDS, with a normal or even decreased in aplastic anemia, whether acquired or inherited. Large granular lymphocytosis is more common with the hypoplastic MDS. Karyotyping and FISH analysis. FISH analysis using for the deletion chromosome 7 or deletion 7q, deletion 5 or deletion 5q, which is the panel of the MDS panel. They have both diagnostic and prognostic significance in both hypoplastic MDS and aplastic anemia. The monocyte 7 in a child should point for evaluation of a germline SMAD9 and SMAD9L or GATA2 variant, and a test for Fanconi, dyskeratosis, and Schwarzman-Diamond syndrome. Deletion 7 or 7q is more common in a post-aplastic anemia MDS than in primary hypoplastic MDS. Exclusion of secondary causes of hypoplastic bone marrow: B12, folate, iron studies, thyroid, liver functions, viral serology, autoimmune disease, immunoglobulins, where hypogammaglobulinemia may be due to GATA2 deficiency, the TPMT gene, which is a gene required for thiopurine methylation, as bone marrow failures following exposure to 6-thioguanidine or 6-mercaptopurine or azathioprine may result from the germline mutations affecting this gene. According to laboratory and clinical findings, together with genetics findings, the Bono et al., integrating the three together, found a score. This score is based on a scoring system based on bone marrow blasts or the CD34 positive cells being more than 5, ring sideroblasts being more or equal to 15, the presumptive cytogenetic abnormalities defining the MDS being all three receiving a score of 2, while other parameters such as bone marrow fibrosis, dysmegakaryopoiesis, a blast cell less than 5, or ring sideroblast less than 15, severe dysgranulopoiesis, and somatic mutations receiving a score of 1. A score of more or equal to 2 was more specific for hypoplastic MDS compared to aplastic anemia. So as we said, we have to differentiate it from hypoplastic AML, and the main differentiating features are the increased blast or the CD34 more than 20%, and an AML defining cytogenetic or molecular abnormality, and absence of the PNH clone. To diagnose the types, we perform a chromosome fragility, which is positive in Fanconi anemia, but we have to take care as Fanconi anemia with somatic mosaicism may give false negative results in the peripheral blood. The telomere length, if less than the first percentile, is diagnostic of dyskeratosis congenita. Next generation sequencing have a role, both in germline, detection of germline mutations and somatic mutations. We have to consider it both in acquired and germline disease, as somatic mutations in germline disease is required for assessment of progression to MDS or AML, while in an acquired bone marrow failure, it has prognostic and potentially therapeutic information. Molecular markers may serve for longitudinal disease monitoring. So, with the complexity of laboratory and clinical findings that have to be integrated to reach a diagnosis, is there a role for artificial intelligence? Well, a difficult name to pronounce, so it's Gutierrez Rodriguez. I Googled it. He constructed a machine learning model based on a two-step data-driven clustering and classification, utilizing 25 clinical and laboratory parameters, including telomere length analysis, and was able to differentiate the inherited bone marrow failures from acquired bone marrow failure syndromes without the use of germline genomic data, which is important in our country because we're short of money, actually. So, I'm done. Conclusions. Hypoplastic bone marrow encompasses multiple overlapping disorders requiring complex diagnostic workup, both clinical and laboratory, immunohistochemistry staining for CD34, flow cytometry for PNH clone, FISH analysis and germline mutation detection are essential for differentiation. Differential diagnosis of hypoplastic MDS from inherited bone marrow failure syndromes should be considered, particularly in young patients. The PNH testing should be performed at the time of diagnosis in patients with unexplained cytopenia in whom aplastic anemia or hypoplastic MDS are the differential diagnostic considerations. Artificial intelligence may differentiate various bone marrow failure disorders. These are my references, and thank you.